Okay, so first of all, of course, thank you so much for these really, really interesting lectures that you've just given. And the first thing I would like to do is actually move back in time a little bit. I know that I have always wondered, Neil, how you came up with the idea, the day you really cracked the idea of constructing this type of device.
Sure, no, thank you, Marcus. So the original concept was I was doing a PhD in Imperial College in London, and I met a colleague in the coffee room, and he was asking me what was new in dentistry, and this was back in 1991, 92, and I said there were dental implants. But I said the issue is that dental implants fail occasionally, and we have no way of predicting and avoiding failure, we just see them fail. And I explained about the changes in osseointegration and stability and how an implant basically was lost. So this colleague of mine was a chap called Peter Corley, and it turned out he was an exceptionally brilliant professor of non-destructive testing and mechanical engineering. So he said, oh, that's easy, we can do that. Yeah, we can measure that. So it wasn't as easy as we thought. So whatever anybody has ever done or tried to do in terms of testing implants by vibrating them, by microwaves, by anything else, we have tried. And resonance frequency analysis was the single best and most accurate method of measuring that stiffness of that interface. Because the human body and the cranium is actually a very complex, not biomechanical, but a very complex acoustic structure with hard and soft tissues. So to get repeatable and reproducible measurements is quite a challenge. And resonance frequency is the very best way to do it. And that was the start.
And at that point in time, I mean, looking at the devices that you've shown in your lectures today, it obviously looked quite different from what we have.
Oh, no, absolutely. So I went to Sweden and did some work in Sweden. So I used to push a trolley around the Brannemark Clinic with a series of frequency response analyzers and laboratory equipment. It took us about 5 minutes to make a measurement. The risk of patient electrocution was very high. So I've seen the changes are dramatic. And one of the things I don't think people will appreciate, because they don't need to, is actually the level of technology and innovation in something like the Beacon. And that's not a sales, that's my voice of admiration in terms of the state of the art that we achieve with Bluetooth, with the processors, with the displays and everything that goes with it. And it's nice. It shouldn't matter to us as clinicians. It should just be easy to use and reliable and repeatable. But that technology has moved so far in the last 20 or 30 years.
And I know that many clinicians are interested as to, when you're working with the devices today, how you really set up the logistics in your office. I mean, I would like to, ask the questions to the clinicians over here, and perhaps Jeff first. I mean, how do you work with this? Because you showed one type of device that are on the implant med, you have the Beacon, you have the IDX. How do you set up this in your office?
Yes. So, is this on? Yeah. In my office, we have 4 surgeons, and we have 4 surgical suites. Not all of us are in the office at once. Usually it's 2 of us doing surgery at any one time. But our drilling units are I think you call them the implant meds. I don't do the ordering, so I'm not. It's the drilling unit with the built-in Osstell device. And because that's so convenient, we will place an implant and then take a measurement. And I didn't mention in my presentation, but if I'm concerned about stability, or if I would like to immediately load an implant, I may sometimes place the implant to my desired height, take a measurement, find that it's not quite as stiff as I'd like it to be, and then insert another half turn or so and watch the ISQ increase just from the result of placing the implant a little bit deeper. So it's very convenient to be able to have all that in one unit and have it all available at that time. When patients come back, they come into a different room. It's not back into the surgical suite. So we have the portable devices available then. I have a couple of different generations. not the original ones where we bolted on the transducers, but now they're all with the smart pegs. And at this point in time, we don't use the Connect feature, although I plan to start using that. And it's just fairly easy for us to remove a provisional or a healing abutment, screw in a smart peg, and check a measurement. And we keep the smart pegs for individual patients. We'll reuse them for that patient, and then when the patient's finished with treatment, we will throw them away.
And then moving on to you, Barry. I mean, do you work in the same manner, or do you have a different setup?
Slightly different, because I
Yeah.
don't have, excuse me, I don't have the combined W and H unit at this point. I'm waiting for one to break, so I have a reason to buy a new unit. But up until about a month ago, we were using the Osstell IDX, which is kind of like working off of an iPad, and that's connected to the cloud. So my assistant will enter the patient's name, tooth number prior to the procedure. I place the implant, I attach the smart peg, take my measurements, and save it, and then it gets uploaded. And then when we go back to follow-up, like Jeff mentioned, we'll use the same smart peg for that patient again, take the follow-up measurement, and then discard the peg. Recently, I started using the Beacon, which from a convenience standpoint is wonderful, because you have this very small, portable, handheld. It's almost like using a toy, except that it's much more expensive than a toy. And you get that visual feedback of the green, yellow, red. And what I've done is I've purchased a small tablet and just go to the Osstell Connect. And when you connect that with the Bluetooth, with the Beacon, your measurements appear in the little box, and then you just save it. So it's become very convenient. I don't have enough experience with Osstell Connect to really expand on any way that I'm using it at this point, other than just storing several patients. But if I just have one of my assistants enter the patient data prior to the procedure.
And there are a few of these questions regarding those technical aspects. I mean, for one thing, of course, going back in history, Neil, I mean, in the beginning, there were very few implant systems that you actually could measure. Nowadays, of course, it's a different story. So a question here that was coming from the audience is as to, can you use Osstell with any implant company? For example, including cochlear implants?
Shall I?
Yeah.
Sorry. So one of the things that Osstell's done, which I think is very important, but is not easy, is to be able to provide transducers for a very large range of implant systems. And it does this, and it has an internal process, I believe, where they calibrate and calculate the variances attributable to differences in geometry and differences in flange shape to be able to compensate for those exactly. And that's terribly important, because it means ISQ is ISQ. So the Osstell transducers give an ISQ value irrespective of the implant system, which is dependable and reliable. And I think that's very important.
One thing that was sort of mentioned in the previous answer as to the logistics around when you're measuring with these smart pegs, and this is also a very common question as to how many times we can use the same smart peg. If you have multiple implants, especially, how do you do that? Barry?
I'm certainly aware that the indication is a one-time use and discard. The cost of a smart peg is relatively low. So, if we use it for one patient on one implant, or if we're placing several implants that have the same smart peg connection related to the prosthetic connection, we may save them for the follow-up reading, and then we discard them. We don't use them over and over. We certainly don't use them across patients. And, it's really not a cost-prohibitive piece of equipment to use. It's almost, well, it is to be thought of almost as a disposable type of piece of equipment, where you're just using it for the one time or possibly the follow-up. So, but I wouldn't take a smart peg from one patient and use it, sterilize it, and use it again on another.
And you address that in your fee for the patient, for the cost that you have, for example?
I mean, the cost, I think in the US it's about $24 for a smart peg, I believe, unless things have changed, which, for patients spending several $1,000s to replace teeth, it's more important for me to have it and to use it than to think of it as a cost prohibitive measure. If you think about every single time you open a vial of bone graft material, it's significantly more costly than a smart peg, but you would never think of not using it. So it's just something that we assume the cost for to get built in for each patient.
Another question that pops up every now and then is, we're talking about measuring a lot on implant level, but what about measuring on abutment level, for example? What differences do we see? I mean, Neil, for example, could you answer this question perhaps?
Yeah, no, sure. You shouldn't see, again, the differences should be compensated for according to the transducer and the way it's attached. We were talking about attaching transducers, and in general, 5 Newton centimeters is a good torque, it's a sensible torque. In general, you will get a totally aberrant reading if there's any soft tissue or if there's any material interposed between the transducer and the abutment or the implant. So that's an important factor. But in terms of attaching to implant abutments, also the interesting one is we're seeing angled solutions now, and indeed angled implants. But we can actually still get a reliable, the direction of the transducer in terms of that context doesn't seem to be affect the ISQ.
Not say from a technical standpoint, but we're talking about measuring on different levels. I mean, you very nicely show that, and there's some questions here asked. When you're seeing different values, for example, here, sometimes the ISQ value is 65 on the buccal side, 75 on the mesial. Do we load the implant or not? What are we looking at?
No, I think that's a very good question, and I think it's so. If we see a different value between the two differences, it means there's an asymmetry. And we will classically see it in extraction sites where obviously the implant bone contact is far greater on one direction than it is on the other. That's a really important parameter to know. I would always, for myself, take the lower value as the most significant. So if I'm seeing a 60 and a 45, I'm quite nervous about that implant. I wouldn't say I wouldn't do, I will be in the same way that we've all been talking about. We used to say spinners and wobblers. So if I have a spinner, then I'm quite confident and I'll place a cover screw and I'll close over and leave and then remeasure at that second period. So it's very useful to have that information about the double values.
Another question which is sort of similar, you're talking about when to decide when to do what. Here we have a question here regarding healing abutment or cover screw. How do we decide when to use one-stage versus two-stage healing?
I think the answer has to go back to your expectation of the healing process and understanding of biology. We know the implant basically can't move while it's healing. If you're confident you can prevent the implant from moving with the cover screw with a healing abutment, then put a healing abutment on it. If you're not confident, then submerge it, because that's an extra layer of protection against movement of the implant during the healing process. ISQ gives you some window into what to expect, because you can tell how stable it is from day one. And it's really the same question as the last one also. If you have this asymmetrical reading and you have a big gap on the buccal of an implant, if you can control the movement of that implant buccal lingually, you could immediately provisionalize it. Barry showed that quite well. On the other hand, if you don't think you can control that movement, don't provisionalize it, because you don't want to interfere with the wound healing. It all comes down to the biology.
I mean, if you take this into consideration, like, so you have very difficult patients. For example, a question here, what protocol do you use for patients using biphosphonates? I mean, would that be like you always do two-stage, or you solely depend on the fact that ISQ will guide you in terms of the clinical decision, when to implant or not? Barry?
I typically will approach, we have, as periodontists, and And Jeff, I think from last night's meal confirmed that I don't have the oldest patient population in the United States, but Jeff does, because all of my patients that retire and move to Florida become Jeff's patients. So, they're all on medications, whether it's bisphosphonates, antihypertensives, cholesterol-lowering medications, you name it. I mean, the list of medications is sometimes endless. Anticoagulants. I think every patient is on an individual basis, and every site in their mouth is an individual situation. A lower molar and an upper incisor is not the same implant site in the same patient. So I typically don't have a protocol where, as you said, bisphosphonate patients have two-stage surgery. I'm in complete agreement with what Jeff just said about the wound healing and the ability to keep that or protect that implant from motion. And that really determines how I may approach these patients. Now, a patient on a bisphosphonate who, we're contemplating loading, if everything else is in order, I will treat them as any other patient. But I think you have to factor all of this in for each individual patient. And so I don't have a set protocol based on medications and so forth.
Nowadays, we're talking a lot about, the fact when we have problems and issues with implants, and peri-implantitis is a sort of a very large topic nowadays. Do you use Osstell and IceQ to measure disease, like peri-implantitis, for example? Do you do that in your office? So you're seeing bone resorption?
I do not. I use radiographs and more clinical parameters because peri-implantitis, almost 100% of the time is going to occur on an integrated, restored implant. And at that point, the ISQ and the whole wound healing process is long past completed. We're now looking at a new disease process on an already integrated implant. So that's my interpretation.
Okay.
I would agree from the standpoint that if I'm treating peri-implantitis, that means that the implant is already integrated. Now, it's an interesting thought if we look at loss of marginal bone, which is what peri-implantitis is by definition, that if we regain that marginal bone in any capacity, do we see a change in ISQ? The biggest problem with measuring ISQ with peri-implantitis in a clinical perspective is that you'd have to remove the restoration to get this measurement. And the majority of restorations, which is thankfully trending back to screw retained, are cement retained. And so this is not a practical task. If the restoration is screw retained and easily removed, it may be a very interesting new parameter to look at.
Neil, what's your opinion?
Yeah, I agree completely. It depends on the individual case. So if I'm treating peri-implantitis, I like to gather as much information as I can. Radiographs are obviously a very good benchmark. But if the restoration is removable, then I will remove it, and it's quite a useful thing because it can increase surgical access for me to the site. And then I will measure ISQ and then measure it over time. I've got a relatively small number of samples, but there is a little bit of an evidence over perhaps 6 to 12 months. You can see an increase in ISQ.
I mean, if it's not peri-implantitis, but you see, bone loss or issues and problems, and you show those a few cases, Barry, in your lecture, and there's a few questions asked, when do we do what? So here's the question. Is it mandatory to remove the implant if the ISQ decreases after 3 months?
It depends.
Yeah.
How much did it decrease? What other clinical parameters are we looking at? If at 3 months post-placement we have significant bone loss, inflammation, suppuration, perhaps. If we have mobility, yes, at 3 months. But not necessarily. It really depends on, maybe we submerge the implant and give it more time.
Yeah. And the case you show with the molar implant, where you saw progressive bone loss, you just waited more or less. You didn't do any active sort of treatment.
No, well, with the one that was at 10 weeks, we saw some crustal. Yeah, I mean, I will tell you, that's about a 4-year-old radiograph, and that patient is in our maintenance population, hasn't lost any more bone, but is very good oral hygiene, and restoration is not in an excessively heavy occlusal loading situation. The case I showed after that, we continued to lose bone, and it was a distal abutment to a bridge. And we tried multiple times to intervene, both surgically and non-surgically. And the problem with implants experiencing peri-implantitis today is that they're so rough on a microscopic level that we still haven't come up with a predictable way to clean that implant to allow osseointegration for every case. So sometimes the best treatment is to remove the implant and just start over.
Another specific question here from one of the participants is, one time I had an ISQ value of 72, and tightening the abutment to 35 newtons, the implant turned and the patient felt pain. What's the explanation of that finding?
Yeah, no, that can happen because the act of tightening the implant can actually, so what we measure with ISQ is axial stability, is a bending moment, which is a good, because it's relative to actual occlusal and functional loading. But there are occasions, and there have been one or two implant surfaces which are prone to this, where the implant actually is integrated. And so you'll achieve a very high level of bone-to-implant contact, and you'll achieve a high level of ISQ. But applying a load of 30 Newton centimeters may be sufficient to actually rupture that interface. And that's what can happen. And if the patient feels pain, then there's a good sign that things aren't as they should be.
Okay. Now moving into sort of the loading concepts, here's a question. Do you combine ISQ measurements with other measures, such as insertion torque, when deciding when to provisionalize or not? But if you could answer that question first.
I think you use all the information you have. I was going to ask Barry, actually, how he measures insertion torque on his studies, because when we are using the motor to place implants, we know what the maximum insertion is set to, but if I stop placing the implant before it hits 45 or 50, the reality is I don't know what that insertion torque is. So I will use insertion torque sort of as a starting point, and then I add the ISQ value to that, and then I'll also look at some other factors. It's a preview for my lecture tomorrow, but I'm going to look at whether we need to do some additional augmentation, what the stability of the surrounding tissue is like, patient expectations, things like that. So we're going to look at everything.
Typically, when I place an implant, I will start with the motor set at 20 Newton centimeters. And as the implant stops turning, we increase it at 5 Newton centimeter increments until it's seated. So we at least know within a 5 Newton centimeter range where we are as far as insertion torque. I mean, hopefully I demonstrated for those who were awake when I was presenting that I'm not a big believer or proponent of these minimum 35, 40, 45, 50 Newton centimeter insertion torques when it comes to loading. Like Jeff said, you have to look at everything. And if an implant goes in with an insertion torque of maybe 20 and the ISQ is 40, I probably will not immediately temporize that implant because I'll have now multiple signs that we should be a little bit more conservative or cautious when it comes to loading. The problem with documenting everything is you've documented everything. So when things don't work, you can only blame yourself if you've documented all these yellow and red flags. But a lot of it is how well can we keep these temporary restorations out of occlusion? What is the patient's compliance to our best guess? And all of these factors combined.
So I agree. I think for me, I will use insertion torque as an assessment, but I won't record it as a parameter. One of the things which Barry alluded to in your discussion, which was very nice about insertion torque, there are lots of parameters which influence insertion torque. And the parameters are the implant diameter, the ratio of the implant to the final osteotomy, the presence of a flange. So a high insertion torque may actually just be the flange hitting the marginal bone, and that's why we see more marginal bone loss. So there's so many different parameters, it's really difficult to say this is a meaningful value. And there's a lot of work and research been done in looking at an insertion torque. One of the areas where torque may be interesting is before we place the implant. And I've been part of a research group which has been looking at actually measuring bone quality by tapping torque. So you very precisely drill a 2 millimeter pilot hole in your site, which we would do anyway, and then place a special tap and make a measurement. And that gives us an indication of the bone quality at different depths, which is helpful in us in making the right choice as the right type of implant. And that's quite exciting. That's measurable. It takes away a number of the variables, and it will be quite interesting to see where that goes.
I mean, you very elegantly show, Barry, in your lecture that, the so-called unicorn. And I remember a few years ago I was attending some lectures, and they were sort of discussing as, 75 Newton centimeters, 150 Newton centimeters, it doesn't matter. There's no damage to the bone done. And companies are almost bragging about the fact that they have so high insertion torque values. I mean, why is it that we're still talking about this?
I wonder the same question, why we're still talking about this. I think the analogy to carpentry is very important, because as more people with maybe lacking some of the training are being encouraged to perform more and more ambitious procedures, everybody feels good when that implant does not move when you place it. And that's a feeling that you will lose once the patient leaves the office. And we're not working on wood, but we're working on living, bleeding, vital tissue. And I don't think there's any reason for optimism that we should try to crush this tissue intentionally, because the long-term goal is to have a stable prosthesis for years to come after treatment. So, certainly we feel good when that implant is stable, especially if we're going to immediately place a temporary restoration. And, really nobody talks about the immediate versus the healed site with insertion torque, as far as the healing capacity of trabecular bone is significantly greater. Even though we still see the microfractures, there's a much richer blood supply to an implant placed in an extraction socket in terms of the bone implant contact and that portion of the osteotomy receiving the implant, because we don't have that poorly vascularized cortical bone. In a healed site, if I'm placing that implant and I get to 50 Newton centimeters and the implant is not seating, I take it out and I open the osteotomy even wider. And I pray I see some bleeding before I put that implant to place. If I don't, and I place it into very dense cortical bone, I don't feel very confident that we're going to not lose some of that marginal bone.
I have a question for you, Neil, here. We're approaching the end of the session now. Looking at all this data that is sort of accumulating in the cloud, you said almost 200,000 measurements. And the facts that we know now that, insertion torque is not the predominant factor that we should look at, might this actually, force the implant companies to be closer to each other in terms of design, maybe? That, that they're going to discard some old ideas and they're going to be more similar in the future?
No, I think that's an interesting question, getting the implant companies to be closer to each other. I think the different geometries that we see today as well as having a reason behind developing them, is a way of the companies differentiating their products. There are also some patents related to those designs which are a factor. And I think it will be very interesting to, I think it could happen in a series of steps. So it's about gathering the data and then differentiating the different systems and understanding what, if any, those changes are between the systems attributable to the geometry. And that's an interesting parameter as well. Osstell Connect collects a lot of parameters in the simplest way. we don't have to fill in lots of forms, and I think that's terribly important. But equally well, I think implant geometry may be a smaller factor. I'm really very interested in diabetes and penicillin allergy and parameters like that. And if we can get hundreds of patients in a group, then I think we can really start to understand the interaction of all these different variables and what are the most significant ones. What are the things that we should really focus on where we have a current risk, either we don't know or we don't manage, and we can improve on the care for our patients.
Looking into the future, where do you see Osstell in 5 years' time? Barry? Where do you see? Yeah, Barry.
Barry,
Yeah.
what do you see?
I mean, I think it's going to continue to grow in terms of its application, because we're becoming an analytics-based society. If you look at every aspect of sports, business, medicine, you know, like Neil pointed out, it's the more knowledge that we can gain from our data, the better decisions we're going to make as clinicians. So I think it would, if the people that are not using this technology are missing a huge piece of the equation as far as how do you perform the most predictable, successful implant treatment. So I don't see where it doesn't just continue to grow and build.
Yeah, Jeff?
I think this is a piece of the armamentarium. It's going to be a commonly used tool in practices, because I think that the trend is to place implants earlier after extraction and to restore them faster. And I just think that this is going to be one of those tools that allows people to confidently implement new changes and better patient outcomes, because there's a level of confidence that goes with using it.
Where you see your baby, Neil, in the future, 5 years from time?
Yeah, no, so I think one of the things that has changed in our lives in the last 20 years, in almost everything we do, and certainly the way we practice as clinicians, is accountability. And we need to be increasingly accountable, and we're called on to be increasingly accountable. And I think Osstell is an independent, quantitative method of measuring implant performance and our success as clinicians, and I think it's a very useful benchmark to have. So if we can present that information if and when we're required, we're doing the right thing in the right way, and I think it's an important tool.
Thank you so much. And dear ladies and gentlemen, we are finishing the session now. And first of all, of course, I would like to thank all the speakers. Excellent. And on behalf of the Osstell and WH company, thank you for attending this morning and taking your time to be here. And of course, we wish you a continuous great meeting and hope that we see you also next year when we're attending in Berlin. So thank you so much.